Imaging is critical for in-stent restenosis evaluation, period. And now that we have new technology with drug-coated balloon therapies, it's really critical to combine these two modalities for treating ISR to get the optimal outcomes. We know from imaging that there are different mechanisms for why stents fail, whether they're underexpanded, whether it's neointimal hyperplasia, neoatherosclerosis, many different contributors that all factor into how we're going to treat that stenotic lesion to get the most optimal outcome. The role of imaging in post-prep assessment is critical. Imaging in our approach for treating ISR lesions always first starts with the initial imaging to understand the underlying mechanisms of why that stent failed. But once we have that information, we move forward with vessel prep, which typically requires some sort of additional treatment, whether a cutting balloon or ablative therapy with an atherectomy device. And once we've done that, we want to confirm good expansion and also sizing to really deliver our definitive therapy, which now in the US is a drug-coated balloon technology. Imaging remains a cornerstone of my practice, whether for ISR or other lesions, but it's, again, considered our standard in our lab for ISR lesions. And I'll give you an example of a recent case where I used an agent DCB. We had previously placed bifurcation stents from the left main into the LAD and the circumflex. The circumflex ostium was restenosed. We imaged. We saw some neointimal hyperplasia. We also saw some underexpansion. We went and we treated that with a cutting device. We then went back. We still saw some underexpansion. We did additional vessel prep, including intravascular lithotripsy. We did imaging again to confirm a really strong lumen that we felt comfortable with. We did our DCB and we were able to finish that procedure with a wonderful angiographic outcome that we could stand behind because of that imaging confirmation. Imaging is absolutely necessary, again, for drug technology, because if you cannot get the vessel opposed to the vessel wall, that drug transfer won't happen. And so it's absolutely critical for sizing with imaging devices to make sure that we are appropriately using the right drug-coated balloon technology to advance the treatment of these in-stent restenotic lesions. So there have been many advances in imaging that have really helped advance our ability to use what's newest technology, in this case, drug-coated balloons, and particularly the really smart measurements that come with newer software programs have been critical for getting the right measurements to guide our next therapeutic decision. And in this case, again, to be able to transfer drug, you have to be against that stent. You have to be very well opposed. Sizing's everything. So that's been a very great advancement for us. AVVIGO has advanced our imaging in our lab for a couple reasons. The first one is we have both older imaging systems and AVVIGO, and the pullback speed is dramatic. So not only is the ability to really be efficient through your procedure improved with the AVVIGO system, but again, I think with the artificial intelligence that's built into that system has made decision-making a lot more objective, where instead of us trying to trace by hand some of these different measurements and make other length and size decisions, we have some really high fidelity measurements being done automatically on the newest system. And so that's changed a lot of our approach. We have a lot of faith in it. It corresponds to how I would do it if I did it manually, which is my benchmark. And it's changed really how we treat in-stent restenosis, period. Patient outcomes is why we're in this business. And so getting a patient a durable treatment response to their intervention is absolutely imperative. Many times us as interventionists, we are a little bit shortchanged because we get to meet the patient on the table and we take care of them for the episode of care, and then they may not return back to us. But we know that stents on average fail at least 2 to 3% per year. And so this is a long-term treatment program for a patient that may involve more than one return to the lab. And so each time we see these patients, it's about how do we get them the longest, most durable outcome, but also thinking about what they might need in the future. So for example, we're focusing on in-stent restenosis. It's easy to put another stent in the stent. But in this case, where we use drug-coated balloons now to avoid another layer of stent, we know we could get patient a really strong long-term outcome, leave options open in the future, think about ways to reduce the risk of stent-related events in the short term, and overall improve the general trajectory of that patient's care. So, this has been a big part of my, change in practice, even of recent times. When we compare and contrast how we use imaging for a de novo lesion versus in-stent restenosis, there's several different approaches and measurements, mechanisms of how we're looking for on those imaging findings. De novo lesions is particularly as an upfront strategy, IVUS-guided PCI. We're thinking a lot about the plaque morphology, in particular calcium. We're looking at measurements from a diameter and length standpoint, understanding overall what our treatment plan is, and then we can go back and confirm that once we've delivered our stent and finalized our approximation. On the different side, on the ISR lesion, it's really important on imaging upfront to do that exploratory work of why that stent failed. And that's why imaging for in-stent restenosis is considered, really standard of care. And so we see that every ISR lesion can behave a little bit differently. And the ones where we think that vessel prep and underexpansion was the main cause, turns out it may not be. It might just be neointimal hyperplasia, even neoatherosclerosis we see. And so we're constantly learning from our imaging technology, and that really guides the next steps in that therapy, and then ending with drug, and drug-coated balloons in particular. Vessel prep is essential for treatment prior to delivery of drug-coated balloon for several reasons. First, again, we speak about the mechanism of failure for in-stent restenosis. If we have an underexpanded stent that we haven't fully addressed, a drug-coated balloon can only go so far before that continues to fail. So vessel prep is key to getting the lumen that you need to really perform optimally in the long term, that scaffold. The second part is drug delivery. And we know that if there is a layer of calcium, for instance, drug is going to have challenges penetrating into the tissue. And so vessel prep is critical also to creating avenues for drug to get to the tissue that it needs to treat, again, to perform well in the long term. There have been many advancements in imaging technology over the year that have helped improve the success of drug-coated balloon-based intervention to in-stent restenosis. Vessel preparation has been critical for several of the cases that I've done to improving the outcomes for drug-coated balloon technology. For instance, in a recent case, we had an ostial circumflex stent that restenosed. And when we looked first under IVUS to understand the mechanism of failure, it was mixed. It was both underexpansion as well as neointimal hyperplasia. The neointimal hyperplasia wasn't the predominant feature, to the point that we thought with a cutting balloon technology, we could both help expand that stent as well as create some fissures in that neointimal hyperplasia that enriches it for the drug-coated balloon. So the combination of therapy between intravascular imaging, vessel prep, and then the definitive therapy with drug-coated balloon technology really is the right toolbox for treating that case in particular of in-stent restenosis. Inadequate vessel preparation for any lesion is a risk for the patient, and in particular for in-stent restenosis. We all have been in our cases where it's easy to pass a balloon, get a better lumen than when the patient came in and walk away. But we know that could just feed a recurrent cycle of that patient returning in months for another procedure. So the only way really to get a good long-term outcome, in particular with newer technology like drug-coated balloons, is to optimize our vessel, optimize our stent, get it to look like a normal, well-expanded opposed stent, and then deliver our drug-coated balloon technology. Otherwise, there's little chance for that drug itself to make all the difference if the stent's already collapsed. Vessel preparation is an integral part of coronary intervention, irrespective of whether this is the first stent being placed or in-stent restenosis. We know that when we are putting in our first stent, the longevity of that stent is dependent on how large that lumen we can get, how opposed and expanded that stent will be, how much drug can communicate with the vessel wall. Drug-coated balloons are no different, and probably even more important for vessel prep. Again, if we know that the mechanism of failure is underexpansion, and we go in and we just try to get away with drug-coated balloon inflation, and that's it, half the mechanism of that is not necessarily keeping tissue from growing again, but that mechanical pressure on the stent. So to address this vessel prep is absolutely key prior to any use of drug-coated technology, in particular drug-coated balloons for in-stent restenosis.